Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Understanding HRSA's 2012 to 2025 Supply-Demand Nursing Projections, and it was presented by George Zangaro and Tim Dall on February 25th, 2015. Now, I would like to go ahead and take a few moments to introduce today's speakers. Dr. George Zangaro is the Director of the National Center for Health Workforce Analysis in the Bureau of Health Workforce at Health Resources and Services Administration. Previously, he served as the Director of the Office of Performance Measurement at HRSA, where he led the development, implementation, and analysis of performance measures across more than 40 different activities. His research interests center on the supply and demand of the health professions workforce. Tim Dall is a health economist in the Life Sciences Division of IHS. He has over 20 years of experience in healthcare research and policy. Presently, his team is developing an integrated health workforce simulation model to model the supply and demand of more than 25 health professions for the National Center for Health Workforce Analysis at HRSA. At this point in time, I will turn the event over to our presenters. After the presentation, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you will be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. And for those of you whose questions we don't get to today, we are planning to answer them and post them online to our website at a later date. So by all means, stay tuned. With that said, George, you should be good to go.
Thank you, Dave, for the introductions. My name is George Zangaro, and I will be presenting the first part of the discussion on how we're going to provide presentation on understanding the supply and demand projection models. So in this brief that we presented, the Future of the Nursing Workforce, National and State Level Projections, 2012 to 25, the brief presented projections on the supply and demand of registered nurses and licensed practical nurses for the U.S. In 2004, HRSA released projections of RN supply and demand that suggested virtually no growth in supply between 2000 and 2020, with the number of new nurse graduates offsetting the expected number of nurses retiring. At that time, the nation was educating approximately 68,000 nurses annually. The report stated that the U.S. was on a path where demand for RNs could exceed supply in 2020. The recommendation was to increase the number of new graduates to approximately 130,000 annually. And nursing responded to this recommendation, and over the next several years, they increased the educational capacity and extended enrollments in the nursing programs. The projections that we've presented in this brief provide an estimate or a forecast of the future RN and LPN nursing workforce. These projections are not a precise prediction of what will occur, due in part to limitations in the workforce projection methodology that's used. HRSA is continuing to refine the projection models and try to increase the accuracy of the estimates that we have. Less emphasis, though, should be placed on the projected supply and demand numbers, and instead focus more on factors that have been identified as influencing the growth and reduction of the nursing workforce. And these factors may include the rapidly changing healthcare delivery systems, the population growth, the growing burden of chronic disease, and demographic shifts. So now I'm going to discuss the nursing model. Next slide. Hit this little button. And our nursing model that was developed is a microsimulation model. In the microsimulation model, we use a probabilistic approach to calculating the supply and demand. And as with any model, there are assumptions that are put into the model. And I've listed our assumptions there that we used for the nursing projection. Now, different scientists that do supply and demand projections may use different assumptions, and different assumptions can result in different end results that are being reported. Some of the ways that these things can differ: we can have different data sources. We may also have different numbers at the start in the supply area. We may say that there's 30,000 nurses in a particular state, and the other scientists doing the projections, they may say that we have more accurate licensure data and there's 26,000. So there's differences that can occur. Categorization of the variables can be different, and all of these things together can affect the supply and demand results. The supply components of our model: we have new entrants. New entrants are categorized as first-time U.S.-educated candidates taking the NCLEX exam. Now, future production of RNs remains consistent with the current rates. So having said that, with new entrants, we could have large swings in enrollment and resulting labor supply. And if these are repeated year after year, that can affect the results as well. So both of which things that I just mentioned, they're very sensitive to what the job market and the economic conditions are doing. The attrition rates. Attrition is based on mortality, retirement, career changes. And then our average hours worked. Those are the average hours per week for those people that are active in the profession. We use a continuous variable for average hours worked. So if someone works 0.6 of an FTE, we calculate it as 0.6. Other models may use a dichotomous variable, and they'll just say if they're below 0.5 hours, they count it as 0.5. If they're between 0.5 and 1, they count them as 1 FTE. So again, there's differences in how models can calculate these. Our next section is the demand components of the model. The demand components consist of changing demographics and also the ACA. We did account for the increased utilization of healthcare services due to the expanded insurance coverage under the ACA in this model. And one other thought around supply. We had put information out about a minimum data set and asking states to develop minimum data sets. Well, there would be an ideal source, or licensure data, using licensure data as an ideal source to get a more accurate estimate of supply. So now I'm going to turn the conversation over to Tim Dall, and he will discuss the nursing model itself.
So what I'm going to do is I'm going to go through in a little bit more detail the technical aspects of the supply and demand modeling, and then turn the time back over to George to talk about some of the study findings. Okay, first of all, I want to give a little bit of a historical background on how this model differs from the nursing models that have been used in the past. Over the past couple decades, HRSA has sponsored a number of workforce studies of different professions. So just some background then on the nursing models that have been used in the past. They've been done in silos, so before the nursing model was just about nursing. Static models in that when we applied certain parameters to the nation, they were assumed to be constant across states. Separate supply and demand models, and the models were updated relatively infrequently because of the high cost to do so, in part because they were different models built by different contractors using different platforms with different methods and assumptions. And also the models in the past have had limited ability to model policy and emerging care delivery models. So what we did with HRSA is we took all of these models that have been built in the past and collapsed them all into one model, and that is called the Health Workforce Simulation Model. As we built this model, some of the things we wanted to be able to do was, of course, address policy and research questions, but also increase the range of scenarios that could be modeled just to reflect uncertainties about future trends. I would note that the version of the model that was used to compute the nursing supply and demand projections might be considered version 1.0. This model has been continued to be updated as we've done work for HRSA to model physicians and other health professions. So as HRSA updates these supply and demand projections periodically for nursing, it will reflect that the model has been refined with additional capabilities. But the idea was to build it on solid theoretical underpinnings, build it to be a dynamic model where the different health professions and medical specialties were integrated, supply and demand linked, and to be able to take into consideration not just the data that's currently available, but data that might become available through the minimum data set or other sources, and then also to allow this to be adapted to a state or a sub-state level. And we'll talk about that later, but part of this was an initiative to build a user-friendly web-based version that could be used by individuals like yourselves. And then, of course, another important component was transparency through technical reports and also presentations like this so that people could understand and maybe open up the black box somewhat. So again, this is version 1.0, and I'm going to talk about the approach for modeling demand first before supply. So this slide right here shows an overview of how this health workforce simulation model was constructed. At the top, we have a population database, and I'll explain how that was created. We have healthcare use patterns. I'll explain how that was created. And we combine those to model demand for healthcare services in hospitals, both inpatient days and emergency visits, ambulatory care through physician offices, outpatient clinics, dental offices doesn't apply for this particular, for nursing. In long-term care scenarios, nursing facilities, residential care, home and hospice, and in other settings where nurses and other health workers are employed. Those that are employed in public type of settings such as government, school health, academia, and then other types of settings, for example, insurance companies, research, and so on. We then take the demand for services and apply these staffing ratios to get the overall demand for healthcare services. Again, this model is simultaneously modeling demand for physicians, advanced practice nurses, physician assistants, RNs, LPNs, and many other health professions. The approach uses what's called the microsimulation approach, where each individual patient is a unit of observation. And to do this, we create a database that has very detailed information on a representative sample of the population in each state, both now and projected out into the future. And then for each person, we simulate based on their health characteristics, their likely demand for healthcare services, and then we aggregate that up to a population level and apply these ratios of providers, for example, encounters per physician or encounters per nurse, and then that is used to estimate full-time equivalent demand for healthcare providers, including nurses. The way we do this is we combine data from the Center for Disease Control's Behavior Risk Factor Surveillance System, the Census Bureau's American Community Survey, the National Nursing Home Survey, and then population projections, both national ones that are put out by the U.S. Census Bureau, as well as individual state projections. And we use this to create a profile for each person in this representative sample. Later, I'll talk about some of the variables that are in there, but it's your basic demographics, insurance, socioeconomic things like household income, presence of different chronic conditions, and that's used to model the demand for services. So the way we do this is we start with the American Community Survey, and for each person in the American Community Survey that is in a non-institutional setting, in other words, they're not in a nursing home, we match them to someone from the Behavior Risk Factor Surveillance System, which is a community-based survey. For each person is in an institutionalized setting, in particular a nursing home, we map them to someone from the National Nursing Home Survey so that we can capture the fact that people in nursing homes are systematically different from people living in the community in terms of their health risk factors. This table right here, I'll just quickly explain how we model the demand for services. This is actually an example modeling the demand for cardiology-related services. So it would only apply to nurses in the sense that some nurses might work in cardiology offices, some are working in emergency settings, and some are working in hospital inpatient care settings. And the way to interpret this is as follows. So if and the variables under the parameters, the different variables, these are things that we're tracking in the model for each person: their race, ethnicity, their gender, their age, whether or not they smoke, whether or not they have different chronic conditions like diabetes and cardiovascular disease, whether they're insured, and if they are insured, is it through Medicare or Medicaid, household income levels, body weight, if it's normal, overweight, or obese, and whether or not they live in a metropolitan area or a non-metropolitan area. And from this example, if you look at, for the example, non-Hispanic Black, their use of office visits is only about 73% as high as that of the omitted group, which is in this case is non-Hispanic other. Their use of outpatient service or outpatient visits is higher. Their use of emergency visits is higher, and their use of hospitalizations is higher. So as one would expect for modeling the demand for cardiology services, it's highly related to age. It's highly related to presence of things like heart disease and hypertension and having insurance. There's prediction equations like this for approximately 30 different physician office types, for emergency care for about 20 different categories of emergency care, for about 24 different categories of inpatient care, as well as for things like home health visits and other care delivery settings. So when we apply those prediction equations to the changing demographics of the population and also taking into account expanded medical coverage under the Affordable Care Act, we can model the expected growth in demand for emergency visits, home health, office visits, and so on. When we model things like increase in hospital inpatient days, we're looking at both the people admitted for different categories of reasons, plus also the expected length of stay, given that they're in there, and we combine these to model the demand for nurses in a hospital inpatient setting. Again, when we're modeling for other settings like physician office visits and outpatient services in general, like outpatient clinics, that we're modeling it again by the type of provider, as well as major categories like diagnosis codes for emergency visits and inpatient care. Okay. This slide right here, that's a repeat. There we go. Shows that inpatient care related to nephrology is expected to increase by about 37% between 2013 and 2025, whereas inpatient care for obstetrics and gynecology and psychiatry growing much slower relative to nephrology, vascular surgery, pulmonology, cardiology. So within a hospital, we would expect, as one might suspect, demand for cardiology services and nurses that work in a cardiology type of a unit is likely to grow much faster than nurses working, say, in a birthing center or related to psychiatry. Okay, so on this slide right here, we show that once we model the demand for services, we then model the demand for nurses, both RNs and LPNs, to provide those services. So what we do is we first estimate the number of nurses by care delivery setting. We compare that to the projected growth in demand for services in that delivery setting, applying these staffing ratios, and then model the growth in demand for nurses. So, for example, nurses working in a hospital inpatient setting, the demand driver for them is how fast is the demand for inpatient days growing. Emergency visits, or emergency settings, emergency visits, and so on. Okay. I would note there's a few things. School health, we use the population age 5 to 18 as the growth driver for the demand for school-based nurses. And for nursing facilities and residential care facilities, the driver that we're using is the growth in the elderly population age 75 and over as a proxy for how demand for services in those settings might grow over time. Okay. So we start then by estimating the employment of nurses across settings. And for this particular study, we used information from the Bureau of Labor Statistics Occupational Employment Statistics to look at how nurses are distributed across the settings, taking into account a few nuances, for example, that in that setting they didn't have nurses in a community health or public setting, so we adapted those distributions slightly with information from other sources. For the licensed practical nurses, we used information from the American Community Survey. It's a little bit older data, and we combined a few years of data to increase the sample size there. So once we took the total nurses and distributed them across these settings, we could estimate full-time equivalent nurses in these settings, and then by dividing the number of nurses in each setting by the total amount of care provided in that setting, we would get ratios like the following. So the way we interpret this for office visits is that for approximately every 4,469 visits to a physician's office, that would increase the demand for registered nurses by 1 nurse. Recognizing that not all office visits would actually, a patient would actually see a registered nurse, and that in some offices they don't even employ registered nurses, but in others that they do. And so these are based, again, on national total visits divided by national estimates of the FTE nurses working in that particular setting. Okay, now I'm going to talk about the nursing supply. So as George mentioned, we also use a microsimulation approach for nursing supply, where we first start with the number of nurses, and for each existing nurse, we simulate over the course of their career their likely workforce participation patterns. How many hours am I going to work if I'm in the workforce? When will I retire? Am I going to remain working in this particular state? Will I move to another state? So the process then starts with an existing database of the number of registered nurses and also licensed practical nurses. The data that we had available to us came primarily from the American Community Survey, and I'll talk about that versus licensure databases that states have available to them for nurses later in the presentation. And then for each year, we model new entrants, attrition, and other activities such as do their hours work change, do they change their education level, and we model some geographic mobility, although that is an area of ongoing research. Okay, and this diagram just states the same thing in visual format. Start with the current supply, add new entrants each year, subtract those nurses that retire, and that gives us the next year's supply, and then that process repeats itself year after year. So we start with the number of nurses, and as mentioned, we use the American Community Survey. To increase the sample size for states, in particular for some of the smaller states, we actually pulled the 2006 through 2012 files of the American Community Survey. And then we actually calibrated it then to each state's level of RNs and LPNs in the 2012 survey, but using the age distribution that we calculated, combining multiple years of data. And this is what the starting age distribution of nurses looks like. And for supply, we're actually tracking the nurses by whether or not they have a baccalaureate degree in nursing, whether they graduated at the associated diploma level, or whether they have a graduate degree. The reason we track it by those different education levels is that the hours work patterns and retirement patterns differ by those categories, and in particular, nurses that are trained at a higher education level tend to work more hours and tend to remain in the workforce longer relative to those nurses with with fewer years of training, of education. We look at the number of new entrants. As George mentioned, we use information from the NCLEX exam on the number of first-time takers, recognizing that sometimes it might take a few times for nurses to complete, to pass the NCLEX exam and formally enter the workforce. We also make assumptions about the nurses that will change their education level during the course of their career, and I'll talk about that in a moment. We look at the age distribution of the new nurses coming in, and we also look at the gender distribution, with somewhere in the neighborhood of about 15% of new RN entries being male relative to lower numbers in earlier years. We have analyzed various data sources, in particular the sample survey of registered nurses being one of those, to understand what the patterns are of nurses that change their education level. We model that each year about 16,000 RNs will leave to become an advanced practice nurse, recognizing that that number has been trending up. And over the past few years, the number might have been a little below that 16,000, but it's been trending up. And so we assume about 16,000 per year. We also model that about 16,000 licensed practical nurses per year will leave the LPN workforce to become an RN. We model the probability that a nurse will be active in the nursing workforce, and we do this using the American Community Survey. I would note that this is an area where I think that there needs to be additional research. The American Community Survey has its limitations. For those nurses under age 50, we use labor force participation rates that are calculated directly from the American Community Survey based on questions about whether they're active in the workforce or not. The challenge is that if a nurse leaves the workforce for an extended period of time, then they are no longer identified as a nurse in the American Community Survey, and so you lose track of nurses that are not active but at one time were a nurse. So for modeling nurses age 50 and over, we use information on labor force participation patterns for people with a similar education level, separate for men and women, and apply those. So for example, that women that are trained at a baccalaureate level and men that are trained at a baccalaureate level, we use those as a proxy for male and female nurses that are trained at a baccalaureate level. This chart right here shows that if we train 100 new nurses, that during their 20s and 30s and 40s, that we've got somewhere in the kind of low to mid 90% that remain active in the workforce, and then that starts to drop very quickly in the mid-50s and into the 60s, so that by approximately age 64, we're down to maybe 40% of those nurses still active in the workforce. By age 74, about 10% still active in the workforce, and then we assume that by age 75, all nurses have retired, recognizing that there are some that could still be working, but very small numbers. This chart right here just shows the current age distribution and a projected age distribution under our status quo scenario. You can see that the dotted blue line, there's a large number of nurses that are in their mid to late 40s through their mid to late 50s, and that we anticipate that those nurses will start to retire off very, very soon within the next decade here, both a combination of their aging, but also partly as the economy rebounds, we would anticipate that some of those nurses might leave the workforce. We modeled supply under a variety of scenarios. On the supply side, we looked at the sensitivity of the projections to changes in retirement. What happens if nurses start to retire earlier or later compared to historical patterns? The issue here is that some of the data that was analyzed, this is data that was collected overlapping when the United States was in a recession. And so the question then is, as we come out of the recession, will nurses tend to have retirement patterns and hours work patterns that were more like what they were before the recession or more like what they are currently? So we did sensitivity analysis around that. We also looked at what would happen if we increased or decreased the number of nurse graduates. And the main takeaway point here is that the solid black line, which is our baseline demand numbers that take into account changing demographics and expanded medical coverage under the Affordable Care Act, is lower than the supply for most of the specialties. Now, one thing to note on the y-axis, this starts at 2.8 million nurses. So even though in this graph it looks like the spread of nurses is quite large, just note that it is starting at 2.8 million nurses, and so it's actually a lot closer than what it looks like on this particular graph. We did the same thing with licensed practical nurses, again looking at demand, looking at various supply scenarios, and in almost all of the cases we modeled that the supply of LPNs is likely to exceed demand under our baseline scenario by 2025. I would note that supply and demand are assumed to start in equilibrium in 2012. What that means is that when we model the demand for nursing services, for nurses, we're implicitly modeling a 2012 level of care. That is, staffing patterns that are existent in 2012 in terms of nurses per inpatient days, nurses per office visits, nurses per emergency visit, and so on, that those staffing levels would remain constant over time. Work that we've been doing right now is looking at emerging care delivery models such as accountable care organizations and how that might affect demand for services and potential staffing. And I anticipate that when these projections are updated in a future year, that there will be more analysis and sensitivity analysis around the potential for changes in care delivery patterns. This slide right here is, you can see that most of the states are the same color. This is modeling the future supply of registered nurses under a migration assumption that the new nurses will go to those areas, those states where there's the greatest demand for their services. So where there's in states where there's perhaps a gap between supply and demand, the new nurses are going to go there and fill that gap. And if that happens at the national level, we should have an adequate supply and perhaps a slight oversupply, but not a very large one by 2025. We also modeled under scenario that the nurses that are trained in each state remain in that state. And if that were to happen, what you can see is that some states would have an abundance of nurses, while other states, in particular those that have fast-growing populations, that they are not able to keep, under their current numbers being trained, they might not be able to keep up with the growth in demand for services. So we suspect that the actual numbers of nurses in each state will be some mix of the two scenarios, that some nurses will migrate out of their state, some nurses will remain in their state, and some states will adapt, whether increasing or decreasing their training capacity to meet the projected demand for services. This is also the LPNs under a no migration scenario, and again you can see that some states that have rapidly growing populations might not be training enough LPNs to meet the growth in demand for services in their particular states, and so they might ramp up production, or they might be able to attract LPNs from other states. Okay, so the final slide on the technical part, again, this is the nursing model 1.0. Since this study was produced, enhancements have continued to be made to this model. We're now at what we might call version 2.0, and it keeps being refined. The part of the rationale for putting all of HRSA's workforce projections for the different occupations under one model is that it's easier to maintain and update. Annual updates with key data such as the American Community Survey, Behavioral Risk Factor Surveillance System, Medical Expenditure Panel Survey, Nationwide Inpatient Sample, state and national population projections, and so on. Also that the latest research could be incorporated into the model, in particular around migration patterns and how economic variables might affect labor force participation rates and migration patterns. New and emerging care delivery models, evolving scope of practice, in particular things like team-based care, accountable care organizations, changing technology, that all of this information could be built into the model and updated periodically. As George mentioned, we recognize that in particular on the supply side that states have more complete data than is available at the national level, in particular through the American Community Survey or available through the Bureau of Labor Statistics. This led to a decision to create a web-based, a simplified version of this workforce model that will allow states to upload their own supply numbers from their licensure files and run their own supply scenarios for comparison against demand. Right now, that model doesn't have the ability for states to run demand scenarios, just supply. But it also, as George mentioned, underscores the importance of the minimum database for nursing so that we can actually get the best projections possible for individual states. So with that, I'm going to turn this back over to George.
I'm going to start out now by discussing the key findings from the report. The national findings, supply of both RNs and LPNs is going to exceed demand in 2025. So the brief that we did, the analysis that we did, projects that at the national level, supply of both RNs and LPNs will exceed demand, while there's distributional imbalances at the state level. The brief notes that the projections do not account for emerging care delivery models, which may result in increased demand for nurses. A key finding in this brief is the nation continues to train the current number of nurses at 150,000 RNs and 64,000 LPNs per year. Absent substantial changes in factors including influencing supply and demand, future supply will likely exceed demand, resulting in an excess capacity between 236,000 and 340,000 RNs, and an excess capacity of about 60,000 LPNs. While these projections provide an estimate or forecast of the future RN and LPN nursing workforce, they do not consider individual nursing specialty areas or advanced practice nurses. At the state level, the national findings mask distributional imbalances at the state level. And we reported in our report 16 states had a shortage of RNs. So with state-level licensure data, if we had access to state-level licensure data from a minimum data set type of situation, more accurate projections could be made for at the state levels and at the national levels. So if a state runs their, once we get the web-based model up and states have the ability to enter their licensure data in, their shortages and surpluses may be different from ours. We also ran alternative scenarios. And since the 1980s, the annual number of nurse graduates has been cyclical and characterized by both low and high growth. Alternative scenarios, the alternative scenarios that we ran, we used some different assumptions. For example, if demand for the RNs returns to the pre-recession levels prior to 2007, the surplus will decline significantly to about 236 RNs in 2025. And if we looked at a decrease in people choosing nursing as a career, or a combination of early retirement and decreased graduation rates, we may have a sufficient number of nurses, and it would erase the surplus of the RNs. So, or it may be sufficient to erase the surplus of RNs, and we'd end up maybe with a shortfall of about 86,000 RNs. If we adjust the number of new graduates to approximately 126 to 133,000 a year, and this is based on our current assumptions that we have in our model, the supply and demand may be balanced by 2025, which is, of course, is you know, a goal for nursing to balance the supply and demand. The implications for these findings. The report strengthens the position that there will be an adequate supply of nurses to meet the increased numbers of individuals receiving care due to the expanded insurance coverage. The increased supply of nurses allows for greater flexibility to fill expanding roles in a changing healthcare delivery system and provide safe, quality care to our nation's population. Nurses provide a wide range of services and fill many different roles in rural and urban settings. And these roles are expected to expand as care coordination and prevention become more central to healthcare delivery. Patient care coordination, preventative services, chronic disease management lead to a greater need for RNs, and may lead to a greater need for RNs, and this brief may then have underestimated the demand for RNs, given the changes in the delivery systems. Trends in the nursing projections suggest that there's a greater need to focus on distribution and diversity of the RN and LPN workforce. For states with sufficient nurses overall, there'll be a need for healthcare providers in underserved areas or for underserved populations. The nursing projections showed that 16 states will have shortages of RNs, and 22 states will have shortages of LPNs. HRSA's investments. HRSA's investments work to address the need for distribution and diversity in the nursing workforce. And they focus to prepare nurses to work in a rapidly changing healthcare environment to ensure safe, quality, effective care. They support nursing in rural and urban underserved areas and foster the adoption of new and expanding nursing roles and competencies. Specifically, HRSA's programs focus on curriculum development, enhancing nursing skills and competencies, increasing nurses that are out working in primary care settings, and they play a critical role in developing, distributing, and retaining a diverse and culturally competent workforce. We need to focus not only on the delivery system changes, but on the competencies of the workers delivering care in our systems. So, in conclusion, the projections are a planning tool for the nursing leaders. And when I say nursing leaders, I'm including the nurse educators in there as well. The workforce projections should be used as a planning tool to address factors that affect changes in the workforce over time. Nursing leaders at the national and state levels can determine what factors are having the greatest impact on the nursing workforce and implement strategies to optimize the future nursing workforce. Supply and demand is going to continue to be affected by numerous factors, as I had mentioned: population growth, the aging of the nation's population, overall economic conditions, aging of the workforce, changes in the delivery systems, and reimbursement issues are also going to impact supply and demand. An important question that I believe we need to ask, and I've talked to other scientists that are working in this area and have health workforce centers about this. And is your state, in a particular state, do you have the right composition of nurses in specific geographical areas and in specific specialties? And also, do the nurses that we are training, do they have the right skills and competencies needed to provide quality care to the population? You know, we're focusing a lot on the changing delivery systems, but I think we need, in some respects, to shift our focus to look at the skills and competencies of the nurses that are being trained, and are they receiving the right training to be working in these new environments? In closing, these projections provide an estimate or a forecast of the future RN and LPN nursing workforce and are not a precise prediction of what will occur in the future. As such, readers should place less emphasis on the projected supply and demand numbers and focus more on the factors that have been identified as influencing the growth and or reduction of the nursing workforce. HRSA is going to continue to refine the health workforce projection models on a regular basis to continue to assess the impacts on the nursing workforce. We're planning to put out another set of projections in 2016. And as Tim Dall had stated, there are areas that we're researching in more detail to try to improve the model and improve our estimates and our projections. The nursing web-based model that Tim had mentioned, we hope we will have that live this summer is our goal. And states will be able to enter licensure data, or state-level data, into this web-based model and determine shortages and surpluses in their state. And they can make comparisons to the projections that we've put out, and probably will find that they may be different because, again, the licensure data is probably or is more accurate than the data that we get from the American Community Survey for the reasons that Tim had mentioned. So that concludes my presentation, and I'll turn it back over now to Dave Armstrong.
Thank you, George. That was a great presentation, and thank you, Tim. At this point in time, we'll go ahead and open up the Q&A session. Once more, you may ask questions using the chat panel on your screen. And please make sure you direct your questions to all panelists. And for those of you whose questions we don't get to today, we are planning to answer them and post them to our website in the near future. Okay, George, I believe this first question is for you. This study shows a projected surplus of more than 340,000 RNs and 59,000 LPNs. What will HRSA do to address this?
Thank you, Dave. The report itself describes the data and approach used to project future supply and demand for nurses and presents results under alternative scenarios. So on the supply side, we have a status quo supply scenario, which Tim explained, that assumes the continuation of current numbers of nurses being educated and current labor force participation rates. The alternative supply scenarios model the implications of educating more or fewer nurses and changes in the labor force participation patterns. On the demand side, the scenario models the implications of changing demographics, but assumes that care use and delivery patterns remained unchanged. So with the projection model, the healthcare delivery is changing rapidly, which is not forecasted in the model. These projections provide an estimate or a forecast of the future nursing workforce. They're not a precise prediction of what will occur, due in part to the limitations in some of the workforce projection methodology used. Making projections on supply of and demand for a nursing workforce is complex and must account for numerous factors, including rapidly changing healthcare delivery systems, medical advances, economic conditions, healthcare reimbursement policies, and population growth and demographic shifts. As we better understand the impact of and the relationship between the dynamics, HRSA will refine the healthcare workforce projection models on a regular basis in order to better assess the effect of these impacts on the demand for healthcare professionals. As such, as I had stated before, readers should place less emphasis on the projected supply and demand numbers and focus more on the factors that have been identified as influencing growth and reduction of the nursing workforce. As far as HRSA investments go, I had discussed that they're focused on enhancing curriculum for advanced practice nurses, and they ensure that they're exposed to training opportunities in underserved areas and prepare nurses to provide safe, quality care with complex practice-based environments and in an evolving healthcare system. Although we don't estimate that the supply of nurses will exceed the demand for nurses by 2025, maldistribution of nurses is projected to be a continued problem and needs to be addressed. Some areas of the country have a supply of nurses well above the national norm or average, where other areas have a supply that's inadequate to meet the needs of the region. HRSA is committed to working with states, academic institutions, professional associations, healthcare delivery networks and facilities, and other key stakeholders to address current and anticipated regional shortages of nurses.
I believe the next question is for Tim. What do the nursing projections assume about changes in the healthcare delivery, such as accountable care organizations? How about changes in the role of nursing, for example, as care coordinators affect the supply and demand for nurses?
Yeah, so again, this is version 1.0 of the model, and under the scenarios modeled on the demand side, we assume that care delivery patterns will remain unchanged over time. We know that that actually will not occur and that they will change, and hence the need for frequent updates and continued research. So the work that we're doing right now is understanding how will better use of integrated care delivery models like accountable care organizations, how will that affect the use of healthcare services, and then how are different types of institutions changing their staffing to, basically to use nurses and other health providers maybe in place of more expensive providers. So that's just an area for ongoing research.
Thanks, Tim. And once more, this one's for you, George. How should states use the workforce projection information in this study?
Well, although the national level findings presented in the brief suggest a potential future national supply of RNs and LPNs that's adequate, variations exist regionally and by state. These projections provide an estimate or a forecast of the future nursing workforce. They're not a precise prediction of what will occur, So states should place less emphasis on the specific projected supply and demand numbers and focus more on the factors that influence the growth and reduction of the nursing workforce. State workforce centers and education institutions may consider comparing these projections with projected growth in their states and or supply of RNs and LPNs and develop strategic initiatives to recruit and retain nurses. State workforce centers might also consider evaluating the migration patterns of nurses in their states to determine if nurses are working in the state in which they're licensed. Finally, states could consider reassessing their current educational capacity, enrollment plans, and their strategy to either attract nurses from other states or the strategy to productively place new graduates in rewarding careers if their state is a net exporter of nurse graduates. HRSA is also developing a new modeling tool, which is the web-based model that we spoke about, and it will enable states to use their own data to produce state projections to predict shortages and surpluses. And we hope to be launching that tool. Our plan is to launch it this summer.
Yeah, David, I would just note also that state-level projections by their nature will be less precise than the national projections because of the limited research that's been conducted on how nurses might move from one state to another based on adequacy of supply in one state versus another and changing economic conditions. So the state-level projections will be less precise than the national projections.
Thank you. Okay, Tim, this one's for you. How do I interpret the study findings if my own state's licensure file indicates our starting supply is higher or lower than HRSA's supply projections?
Yeah, good question. So when one looks at the demand for nursing services in a state, the question is relative to what? What is your benchmark? One can look at it relative to national averages and say that in my state, the supply of nurses is either lower or higher than the level I would need to provide a national average level. For this particular study, we made the decision to assume that supply and demand were in equilibrium in each state.
Thank you. I believe we have time for one last question. George, this one's for you. What is the point of doing projections if we don't know how healthcare delivery will work in the future?
Well, supply and demand projections are based on estimates of rates of change of factors, graduation rates, labor force participation rates, attrition, et cetera, all the things that we had discussed. And these affect the workforce over time. The workforce projection model is a critical way for any profession to address factors that affect changes in the workforce over time and determine how they relate to one another. By providing an understanding of these factors that affect supply and demand, nursing leaders at the national and state levels can determine what factors have the greatest impact on the nursing workforce and implement strategies to optimize the future nursing workforce. And, you know, these models, we have modeled not only nursing, but we've modeled other professions along with nursing.
All right, thank you. Thank you, Tim, and thank you, George. It was a wonderful presentation. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.